if we focus on now, today liquid biopsy is part of clinical practice in non-small cell lung cancer patients management, because we can use liquid biopsy in 2 different settings. In example, in Europe, when we not having enough tissue in basal setting, we can proceed by analyzing the clinical relevant biomarkers like EGFR, KRAS, BRAF, ALK, ROS1, RET, and 3K on liquid biopsy. Or at resistance disease, when we need to reanalyze the mutational status of patients before to proceed with a tissue collection, we can use as a blood first approach, the liquid biopsy, and we can detect the mechanism of resistance to a first line therapy, in example, and we can proceed with another treatment option. And this is the current use of liquid biopsy. But if we see an example, the last statement paper from International Association for the Study of Lung Cancer, we have the possibility to use liquid biopsy in 3 different approaches. The first one is the sequential approach, the approach that we have discussed at resistance disease, in example. The third one is the blood first approach. This is really used in the FDA zone, in which you have the ability to analyze directly on blood the presence of an alteration, and you can proceed directly with the treatment. But in my personal opinion, the future and the best approach in the liquid biopsy field is the complementary one. The possibility that we have to simultaneously analyze tissue and liquid biopsy. In this way, we have a comprehensive view of the heterogeneous distribution of different type of alteration, and we can decide in relation to the clinical future or in relation to the mutational status that we have found in liquid biopsy or in tissue. If we have some discordances, we can focus these discordances, and we can use these as a sort of key weapon to better stratify the clinical management of non-small cell lung cancer patients.